So we are starting the next session on basic and recent advances in glaucoma. So I would request Dr. Raveen to join.
It's going to be strict protocol, 7 minutes, audiovisual. Make sure that you give a good buzz, 7 minutes, the slide session off. Okay?
So, respected chair and delegates, good afternoon. So, I'm Dr. Mithun Tulasidas. Today, I'll be talking about 24-hour diurnal intraocular pressure and water drinking test.
Can you have the slides, please?
Okay. Yeah, so basically, what is a quality-based IOP control? So it includes major 4 factors, that is the mean IOP reduction, 24-hour IOP fluctuation control, a long-term IOP control and visual field stability, and a good response rate. So these 4 factors, along with patient adherence, compliance, and persistence, makes it a quality-based IOP control. Now, what is the importance of 24-hour diurnal intraocular pressure in the current practice? So, there were studies which showed that a 24-hour monitoring resulted in a change of clinical management in around 79% of the patients. So, as you can see in the pictorial representation, the mean IOP differed by around 4 to 5 mm and the peak IOP differed by 12 millimeters of mercury when they compared the diurnal pressure with the in-office pressure. So definitely when the peak IOP values are far different from the in-office values, it definitely makes a difference in the management of the patients. Now when it comes to angle closure also, there is a 24-hour diurnal fluctuation which is more often in PACG and PAC eyes rather than PACS. So basically it correlates with the degree of peripheral anterior synechia and visual field loss, because if the peak IOP is more, then those patients will have more chance of PAS and visual field loss. So instantaneous IOP fluctuations can happen with many factors like size, change of body position, when you drink a lot of water or when you take exercise. So a sudden increase in IOP can occur with drinking of water, which we'll come to later. Lying positions, that is a supine position, is shown to increase the IOP compared to a sitting position. Most of the time in office hours we check the intraocular pressure in sitting position, but a nocturnal supine position will definitely show an increased intraocular pressure. And other autoregulatory mechanisms will also play a role. Now, how will we actually check the 24-hour diurnal intraocular pressure? Because we don't have much of devices which is readily usable to check the 24-hour IOP. So one device which is in literature which they use commonly is the contact lens sensor triggerfish by Sensibet. However, it does have its own side effects because basically it measures intraocular pressure in millivolts and not in millimeters of mercury, which is a drawback, and other side effects related to cornea. Other device we have the home tonometers, which also we can use, and something known as iMate, but all these are not very standardized ways of checking 24-hour diurnal intraocular pressure. However, the basic concept is that you can see when they checked using these devices, there was a nocturnal acrophase which is seen in all the patients, but it was more marked in glaucoma. Even healthy subjects, as you can see the blue line, there was a spike in the intraocular pressure, but it was more marked when it came to primary open angle glaucoma patients. And there are two concepts. So there is a short-term IOP fluctuation and a long-term IOP fluctuation. So what is the importance of both? Most of the time we end up doing the long-term IOP fluctuation, that we check the IOP over a period of weeks or months, measured on several occasions, and we will come to a picture. But actually that doesn't matter. It is a short-term IOP fluctuation which is actually the IOP difference between the highest and lowest IOP over the course of 24 to 48 hours. This actually was identified as a risk factor for increase in visual field defects or increase in the cup area during 48 hours facing. So that is the importance of short-term IOP fluctuation, and that is the importance of 24-hour diurnal intraocular pressure check. And this is one study which cannot be taken for granted because they just showed the peak IOP varies between different types of glaucomas. However, most of the types will show a peak either in early morning or late night, whereas in secondary open angle glaucoma, they found it in the afternoon phase. So how does nocturnal IOP matter? So nocturnal supine IOP, especially in normal tension glaucoma, so when there is a nocturnal hypotension and a reduced ocular perfusion pressure, it can lead to compromised optic nerve circulation. Along with an elevated IOP due to decreased outflow, hormonal changes, or direct pressure on the globe can also compromise the blood flow. So this basically helps in changing the therapy over 1/3 of patients, and those who had ocular hypertension also need to undergo a 24-hour diurnal intraocular pressure, because those who have a peak IOP more than 30 or those which have the maximum peak IOP are more prone to develop glaucoma in future. Also, it allows detection of false positive normal tension glaucoma among glaucoma suspects. So basically, you can have a personalized treatment based on the 24-hour IOP rhythm. You can actually choose the right time of application of the glaucoma medicine. It may reduce the rate of progression, improve the adherence, and it helps in identification of favorable and adverse behavioral and occupational patterns. So basically, it is an underused or underestimated test, but yes, with setting peak IOP, we can actually set the target IOP and improve the patient adherence. Now, coming to water drinking test, it was initially abandoned due to lost sensitivity and specificity. However, nowadays it has gained sufficient attention. So this is how we perform. Usually the patient will be on liquid fast for 2 hours. Then the baseline IOP will be measured, and a given volume of water, which is actually not standardized. Either you can give 1 liter or 10 ml kg can be given. Then the IOP is measured at 3 to 4 times at 15 minutes interval, and the highest IOP is chosen as the peak IOP. So the mechanism is unclear. It could be due to disturbance in the blood osmolality. It is related to the outflow facility. It can be due to centrally mediated mechanisms or either on the role of choroidal expansion. Now, what is the importance of water drinking test is basically the peak IOP obtained with VDTs, WDTs actually corresponding to the IOP which is done using 24-hour diurnal fluctuation. So these are certain studies which again showed that similar IOP fluctuation and peak values were found in both PSCG and POAG. However, there's a strong correlation with outflow facility. Means if the outflow facility is good, then the peak IOP will be comparatively lesser and the return to baseline will be faster. So to summarize, it cannot be used for the diagnosis of glaucoma, but yes, you can use it as a stress test to evaluate the ability of the eye to deal with transient IOP elevations. And when we don't have much devices for IOP monitoring on a 24-hour basis, WDT is reproducible and shows clinically relevant results validated several times. Thank you for your kind attention.
Thank you. We'll go to the next talk about Dr. Chitra. After that, this podium will have Dr. Ravi Chandra. Is he here? Yeah, Ravi Chandra.
Very good afternoon to the moderators on the dais and friends in the audience. My view is to be relevant to you, talking about the tube options which are available in our country. That's RD, the Ahmed Glaucoma valve, and the Ahmed Clear Path. We all know that they are either the non-valve devices or the valve devices. And in the non-valve devices, there is one is the RD of Orolab, which is of silicone material, and the Ahmed Clear Part is also silicone material. The Ahmed Clear Part comes in 250 and 350 square meters and millimeters, and Orolab is of 350. So the advantage of these non-valve devices is they have a larger surface area, so they bring about an increased IOP lowering. But you have to wait for the encapsulation to occur for the function to happen. So there's a minor delay, so you might need a closer follow-up of these patients. There's a greater risk of hypotony in these eyes, which I will tell you how we can deal with. And because of the larger size, there's a greater risk of diplopia because they impinge on the lens muscles. The valve device is the Ahmed Glaucoma valve device which we are using in our country. Earlier it was in polypropylene, now it comes in silicone. And the commonly used size is 184 millimeter square, although 96 could be used in the pediatric age group. The advantage is there's an immediate post-op IOP lowering, and again it minimizes the post-op hypotony, but then there could be a rapid encapsulation, and again it's a smaller surface area, so less IOP lowering effect. And rarely, if the valve mechanism doesn't work, then you could have hypotonia or obstructed flow. So what is so attractive about RD is one, it's a low cost, and it is similar to the barbell device, but it is the material difference is there. It's a larger surface area, as I said earlier, better intraocular pressure drop. It's lower height. It works by 6 weeks, 40 to 42 days. You can make the intermediate period, the IOP lowering can be done by venting slips, or you can have an orphan trap which you allow the trap to fail, but during that 6 weeks period it works. The risks are hypotony, and to deal with this stenting suture which I will talk about. Hypotony related complications and failure rates could be the downfall, and you need to learn how to hook the muscles, and that is a challenge in learning these surgeries. Any of the quadrants could be used, and we are not very clear that the portion of RD which is underneath the muscle, is it functional or not, and the tube from the RD is a little stiffer, so if you want to insert it in the pars plana, it has an obtuse entry. Now this is a 65-year-old patient who had a pars plana vitrectomy, silicone oil removal, who was on max medications, and there was no full-blown glaucomatous optic neuropathy. The vision was going down. So basically this RD valve implant, you need to, this is placed in inferior quadrant because the silicone oil removal was done in this patient, and it's placed between the two muscles. You can see that you can easily do it, and then you need to fix it to the underlying sclera, and then you ligate these sutures, ligate two ligating sutures in place of 6 micron. Then the intraocular lens was implanted in this patient, and an incision, the tube is cut sideways. The plan of action is to place it in the sulcus, and then 2 millimeter away, you create a flap of 2 to 3 millimeter length, and then 23 gauge needle is passed through the sulcus, and the needle, the tube is passed through this, and then following that, the scleral flap, the anterior part of it is covered with a scleral flap which was raised. And these are my old videos wherein patch graft has been placed. I will explain to you why we don't use it anymore. The first suture placement is a little difficult. It tends to slip, but once you've anchored the two ends, it can be easily placed, and then you need to pull the conjunctiva to cover it completely and suture it. This is another case of a 45-year-old where a belt buckle was used, a scleral buckle was used, post pars plana vitrectomy and a silicone oil injection removal. This was an advanced glaucomatous optic neuropathy. Now, in this particular patient, what was the problem was because the belt buckle was there and this buckle, so there was very little space. There was a lot of fibrosis and scarring which had happened there. So you will see that I'm really struggling to place this RD implant between the muscles, and I'm not going to show you the whole thing, but suffice it to say that what you can do is, in this particular region beyond the holes, I'll show you, you can cut the RD, and that's the big advantage which you have. You can cut it here beyond the holes, and then you'll find that you can easily slide it in, and after that it's anchoring to the sclera and cutting the tube and ligature and the usual things. Now this was a particular patient who had a neovascular glaucoma where Avastin was given multiple times, and then RD implant was, the PRP was done, RD implant was placed. The patient had a patch graft melt, and then a Tenos patch graft was placed, and the suture gave way, and again the patient had a repeat vitreous hemorrhage, and a vitreous lavage was done, Avastin was given. But it was a course of 2 years, but the RD continued to work, and you can see there's little silicone oil in the anterior chamber, but still the RD did well. So this is just a rapid picture I'm show you of same steps are being done, but basically your once the RD is tucked in, and you can see how easily you can place it inside where once you hook the muscles. Now you are raising a scleral graft. Scleral is about 6 millimeter thing is raised, and then what you can do after the priming and the ligature and all that, you close the anterior portion with the sclera, and then the posterior portion is covered with the conjunctiva, and believe me, these patients actually do quite well, and you don't actually need to have a patch graft which has a tendency for the overlying conjunctiva to erode and then have a graft melt. This is again situations where the ace, once the suture gives way, the ace is shallow, there was a fibrin membrane which formed in this patient, and then there was a choroiditis which occurred because of the large size. this particular patient, you can see that the elevation and the adduction got restricted, but the patient was not complaining. There's one way of dealing with the hypotony is you can pass a stenting suture from posteriorly, and then you can ligate it over that, and then the other steps are done in similar fashion. And the other end of the suture, you could place it in the fornix, and this can be pulled, and you can remove the stenting suture much later on. So it takes care of the hypotony related challenges which can occur. I've got very few. The Glaucoma valve is an immediate IOP lowering lower surface area, but since there's a direct conduit with anterior chamber, the inflammatory debris mediators can pass through, and there can be aggressive encapsulation, and that it would fail. You can do a key technique again, which wherein the suture is passed from the opposite end, and you can ligate it and then pull it off. And because it's a greater height, don't place it in the infraradial quadrant, which comes close to the optic nerve. And then if you're going to do a pars plana, you need a Hoffman shoulder. This was a 50-year-old post-DSEC secondary angle closure advanced glaucoma, and this patient had a hypotony, and this is how the cornea failed. And there are some where the glaucoma valve actually extruded, and there was a conjunctival melt. This was a case where there was a patient had an ocular ischemic syndrome, and on the fundus you couldn't make out new vessels, but on the iris there were new vessels, and he had a steamy cornea, and then the RD was placed, and later on the IOP control was not very good, and Ahmed valve was placed, and then later they had to place an RD. You had to remove it in 2 months. MMC usage, see, it is seen that the hypertensive phase is 56 to 82%, and 72% of it is refractory. So there has been usage of mitomycin of 0.1 millimeter over the plate of the HEV, and done intra-op 1 week and 1 month post-op. We have used 0.5 ml and 0.5 ml, and I'm not showing the Ahmed glaucoma valve implant. ACP is a new thing that there's no muscle wounding needed, and it comes with a pre-placed stenting suture, so there's less risk of hypotony, and the tube is a little flimsy. It's just that you need to create a small pocket here, and you can fold the Ahmed clear part like a taco. You can just insert it in, and beyond that you create the pocket anteriorly, so that you can pass the tube and do the steps of the surgery. The main advantage is the low IOP, which is possible with RD and Ahmed clear part, better than Ahmed glaucoma valve. Post-cyclodestructive Ahmed glaucoma for post-buckle, again RD and ACP, because you can easily fold it or cut it. For uveitic glaucoma, Ahmed glaucoma valve. For plate exposure is more with Ahmed glaucoma valve. Diplopia is more with RD. Tube obstruction for reasons unknown is more with RD, and hypotony can be dealt with stenting sutures. This is the last slide of mine where it's a literature search, where interestingly where the Ahmed glaucoma valve implant was compared with the Barbell, and it was seen that the failure rates was less with the Barbell, and less IOP drop was better with the Barbell, but the need for medications was also less, but the resurgery rates were more in that. Similarly, this was another comparative study which showed similar results, but interestingly in the pediatric age group, it was seen that the resurgery was more with Ahmed as compared to the RD. So the final conclusion says that RD gives maximum advantage for the cost, and urgent IOP reduction is possible. You have a lot more area for future procedure, and in cardiac comorbid patients it can be used, especially those with dyslipidemia and all that. And again, the second tube, if you want it, early failure, RD is the best, and stenting suture and key technique for the Ahmed glaucoma is the way forward. Thank you.
Thank you, Dr. Chitra. So now I invite Dr. Ravichandra. Please stick to your time.
Good evening everyone. Today I am going to speak about newer advances in medical management of glaucoma. In the next 7 minutes I will be covering these topics. Conventional anti-glaucoma medications tend to target only either decrease in the aqueous production or increase in the uveioscleral outflow. The newer anti-glaucoma medications aim at decreasing the IOP by newer mechanisms of action, and they can be classically divided into 3 groups, which newer anti-glaucoma medications in clinical use, ongoing clinical medication, clinical trials, and preclinical trials. First, coming on to in clinical use, rho kinase inhibitors are the first newer anti-glaucoma medications introduced. They were cytoskeletically active agents, and they help in regulating the trabecular flow and increasing the trabecular flow, which is a newer mechanism of action. Rho A, B, and C are the family of G proteins, and the isoforms include ROC1 and ROC2. And there are two hypotheses for the mechanism of action. The first hypothesis being they increase the aqueous outflow and decrease the outflow resistance by increasing the ability of the Schlemm's canal endothelial cells to form pores. Second hypothesis being causing the relaxation of smooth muscle fibers in the trabecular meshwork, therefore increasing the outflow. Commercially available Rho kinase inhibitors are ripasudil and netasudil. Both work on ROC1 and ROC2 receptors, and the most commonly reported adverse events include the conjunctival hyperemia, blepharitis, and allergic conjunctivitis. Netasudil, in addition, have a norepinephrine transporter inhibitor action, which can cause the decrease in aqueous production, which was proved in animal studies. And Fastil is a newer Rho kinase inhibitor undergoing clinical trials, and they act as a significant as an adjunctive therapy because the mechanism of action of these Rho kinase inhibitors is different from the pre-existing glaucoma medications. And other potential investigation routes include they help in neuroprotection by increasing the blood flow in the optic nerve, and a proposed role in preventing the post-surgical scarring. However, on the flip side, the side effect profile is relatively high, including conjunctival hyperemia, subconjunctival hemorrhage, and blepharitis, and this may prove to be a deterrent to long-term compliance with these medications. The safety efficacy of these in individuals below 18 years and pregnant and lactating women is not known. And apart from primary open-angle glaucoma and ocular hypertension, that their role in other types of glaucoma is still under investigation. Coming on to latoprostine BU-node, which is a unique nitric oxide donating prostaglandin F2 analog. Actually, it donates two active metabolites, latoprostic acid and nitric oxide, which have two different mechanisms of action. Latoprostic oxide acts like a prostaglandin analog, and it binds to prostaglandin F receptor, increases the uveoscleral outflow similar to prostaglandin. The nitric oxide, which tends to cause vasodilatation, smooth muscle relaxation, decreases the cell contractility and volume, thereby increasing the trabecular outflow. And thus, it is a single molecule which gives two active metabolites which act through two different pathways for reducing the intraocular pressure. And it is more evidence is awaited on its role as adjunctive therapy. It is currently dosed at once daily at bedtime like prostaglandin analogs. Safety profile is not yet established in case of pregnancy and lactation. And frequently reported adverse events include the same as that of prostaglandin analogs like conjunctival hyperemia, eyelash growth, and eye irritation. Coming on to newer drug delivery system, Jurista is the only approved new drug delivery system, which was approved in 2020. It is a sustained release biodegradable implant over a period of 90 days. It uses a specific Novadur drug delivery system for intracameral use, specifically using a 28 gauge single-use pre-filled applicator. And the drug delivery system is made of biodegradable polymers that disintegrate by hydrolysis into carbon dioxide and water. And the indications for this include open-angle glaucoma and ocular hypertension. Contraindications include active or suspected infection, corneal endothelial cell dystrophy, prior corneal transplantation, absent or ruptured posterior capsule, and individuals with history of hypersensitivity to bimetoprost. Although there are no adverse effects related to that of usual side effects related to bimetoprost, the main concern was a drop in corneal endothelial cell density. Newer drug delivery systems ongoing in clinical trials include the bimetoprost ocular ring, which is silicone and polypropylene ring impregnated with bimetoprost and is designed for insertion between upper and lower fornices, continuously releasing bimetoprost for a period of about 6 months. Travoprost punctal plugs are also undergoing trials where there is a sustained delivery of travoprost over 90 days. Nanotechnology includes nanoparticles which are piggybacked onto the drug molecules, which have the ability to bypass the biological barriers and delivering the drug directly at the target site. And the number of nanotechnology these are available: subconjunctival injection of dorzolamide, supraciliary injection of brimonidine, etc. Investigational glaucoma medications include cannabinoids. Basically, they help in neuroprotective effect linked to the inhibition of glaucomate release. Oral cannabinoids tend to have reported demonstrating the IOP reduction. Inhalational cannabinoids report a short duration of IOP reduction, and topical cannabinoids have failed to demonstrate significant effect of IOP in clinical trials. But on the flip side, the relatively short duration of action, risk of developing tachyphylaxis, serious side effects impacting patients' general and neurocognitive health outweigh the potential benefit of this. Coming on to the neuroprotection in glaucoma, which is considered to be the holy grail of glaucoma care. Neuroprotection in glaucoma refers to any non-IOP related intervention that can prevent or delay glaucomatous neurodegeneration independent of IOP. Most important thing in that is the neurotrophins, which have a key role in cell survival. These include brain-derived neurotropic factor, ciliary neurotropic factor, glial cell line derived neurotropic factor, and nerve growth factor. And valproic acid, which is commonly used in treating epilepsy, has also been demonstrated to have neuroprotective effect. However, no human trials are done so far. Coming on to memantine, it's an NMDA receptor antagonist and can prevent cell death by calcium influx. Brimonidine, apart from the IOP lowering effect, has a neuroprotective effect involving upregulation of anti-apotopic factors, modulation of glutamate-induced excitotoxicity, inhibition of nitric oxide synthetase, and inhibition of glial activity. Alternative medicine, dietary supplementation with alpha lipoic acid has shown to decrease oxidative stress. Flavonoids like ginkgo biloba have been demonstrated positive effect on ocular blood flow, and ceticolin, oral ceticolin, has been shown to improve as visual function. Gene therapy still in early stages. Disruption of aquaporin 1 by gene therapy has been going on in animal studies. Adenovirus gene therapy has been also undergoing animal studies. Stem cell therapy helps in regenerating and repopulating retinal ganglion cells and possibly restoring vision lost from glaucoma. And yoga and lifestyle changes. Current literature doesn't prove any evidence to support yoga relaxation techniques in arresting or progression of glaucoma. However, reduction of IOP was noted with certain yoga practices, and certain yoga practices, as shown in this figure, have shown to cause an increase in IOP shortly after beginning. Thank you.
Thank you, Dr. Ravi. Now I would like to invite Dr. Divya Dangeti on role of selective laser trabeculoplasty in primary open-angle glaucoma.
So my topic is to role of selective laser trabeculoplasty in primary open-angle glaucoma and exceptional events. So it all started with in animal studies, like at the end of Schwalb's line and at the anterior end of trabecular meshwork, there are two cells. These are called as Schwalb's cell lines. And when these get stimulated, this produce an effect of IOP reduction. And we'll see this in the subsequent slides how it is possible. So here we get to know what all about trabeculoplasty in glaucoma. So trabeculoplasty, laser trabeculoplasty is done in open angle glaucomas and ocular hypertension, where trabecular meshwork is projected with laser light and which causes IOP lowering effect and prevents further progression. So what are the various laser trabeculoplasties available? Previously, argon laser trabeculoplasty was done where continuous wave lasers energy was used, and now selective laser trabeculoplasty was used, in which pulses of short duration laser energy was projected. How does it work? So argon laser trabeculoplasty, when laser energy is projected, it causes thermal burns in the trabecular meshwork, which causes tissue contraction and further reduction of the diameter of the inner trabecular ring and widens the trabecular spaces. Through these spaces, aqueous outflow is facilitated and further decreasing the intraocular pressure. In ANT, there is disruption of uveal meshwork and creation of ablation craters and coagulation damage is seen. While in SLT, you can see a concept of selective photothermolysis, in which the real criteria of selectively targeting the pigmented trabecular meshwork cells, where in these pigmented cells, melanin serves as a chromophore which selectively absorbs this energy, and the effect is not spread to the collateral tissue, and this prevents the collateral tissue damage, which we can see in ANT. So these are the two pictures where we can see in the left side where the amount of laser energy was absorbed by the entire trabecular meshwork tissue, and in the right side picture, which we can see a selective absorption of laser energy by the selective pigmented cells of the trabecular meshwork. So how does it work? The three different theories were put forth, which includes mechanical theory, which causes contraction of the cells and further increasing the trabecular spaces and increases the aqueous outflow. While in biological theory, the inflammatory mediators were released, which causes alteration in the extracellular matrix of the trabecular meshwork and further cannot happen. We are seeing that means there is collateral damage is happening. And the burns are projected such that there is no space in between the burns. And post-laser trabeculoplasty, IOP is taken after 1 hour, and patient is given topical steroids or NSAIDs can be given for a month. And if the patient is already using anti-glaucoma medication, he can be continued on that. If any IOP spike is noted, a short-term oral anti-glaucoma medications or topical, if severe IOP spike is seen, topical anti-glaucoma medication can also be given. And whom does it work with? It's mostly indicated in primary open-angle glaucomas and ocular hypertension. It can be used as first-line treatment or as on an adjunct to the medical therapy, or who are non-compliant to anti-glaucoma medications. And can also be done in pseudoexfoliative glaucomas, pigmented glaucoma, or non-protection glaucoma, and glaucoma in pseudophilics. And those who are not able to undergo glaucoma treatment surgeries in open-angle glaucomas, and in PSC where the angles are open, and can also this facility will be helpful. And where it cannot be done is in uveitis or in angle decisions where the angle cannot be clearly seen, or in angle distances, and or already previously patient has been underwent multiple times laser trabeculoplasty or closed angles, and younger ages are increased risk factor, and this should be avoided in these individuals. And higher IOP spikes, this SLT is they have less effect when compared to the treatment naive eyes. And in the follow-ups, patient is checked seen in the at 1 week, at 4 weeks, and 2 months for the reduction of the IOP effect. And if the IOP is elevated, the remaining portion can be again retreated after 4 weeks of interval. And the complications which we can see in SLT are very less, as it is a very safe procedure and brings with minimal collateral damage. And the most common side effects which we can see are IOP spike and very minimally uveitis or fast formations, and sometimes patient can have photophobia, congenital hyperkalemia, and feverages, and very rarely corneal burns. And these corneal burns or corneal endothelial damages are very transient and self-limiting. And when compared, when we have seen RCT trials, it showed SLT had a significant IOP reduction, which was comparable with PG analogs, and though it is very less, and it is equally effective in to that of PG analogs. So to conclude, so SLT is having a good IOP effective lowering effect, and it can be used as a primary or an adjunctive treatment with good safety profile, and it can be repeatable as it has a minimal collateral damage, and the side effects were very minimal and self-limiting, and we got reduction in the primary treatment, and patient will have better quality of life. Thank you.
Now we invite Dr. Amit Porwal for speaking about intraoperative gonioscopy, the tips for beginners.
For a presentation on Stop That Leak, Managing Leaking Blebs.
कैसे आ रहा है इसको वैसे मोड में करो ना, फुल स्क्रीन क्यों नहीं आ रहा है Leaking bleb is part of all surgical glaucoma practices and can occur after any filtering surgeries, both in the early and the late post-operative period. And it's like a time, it's a like a ticking time bomb, because if you do not treat it in time, it can lead to serious complications. So therefore, its proper detection and its successful management is paramount. And also, even after you have done it, treated the leak, it is very important to follow these blebs very closely, because there is a high risk of failure of these blebs. So they can be classified as an early leak or a late leak, and incidence is up to 18%. And when we are using antifibrotic agents, incidence can go up to 30%. And the risk factors are obviously a younger age, a patient with a known ocular inflammatory disease, a prior history of an incisional surgery or any other surgery which has touched the conjunctiva, a high myope, a ophthalmic eye, long-term use of anti-glaucoma medications, the surgical technique which you have used, and the type of conjunctival flap which you have, and the type of closure which you have done for the conjunctival flap. So early leaks are usually seen at the limbus or at the incision sites, which are usually because of your incomplete conjunctival closure or because of the wound dehiscence occurring because of excessive use of the antifibrotics or because of an inadvertent conjunctival buttonhole which you probably have missed and not repaired at the time of the primary surgery. And along the suture tracks, depending on what is the type of needle used. So if you use very large spatulated needles for your conjunctival closure instead of using point needles or micro point needles, there is chances that the leaks may occur on the next postoperative day. The amount of tension which you use for closing your conjunctival flap, the amount of tension which you place on the sutures of the while doing the closure, how thin your tissue was because of the previous any other reasons, and whether you have done the closure, especially where you used limbus-based flaps in a single layer or used a double layer closure of the tenons separately and the conjunctiva separately, or it can be sometimes because of the repeated microtrauma of your lid blinking, especially when you have a very, very highly elevated bleb, microcystic, very multiple and microcystic thin blebs. And late leaks are usually because of the use of antifibrotic agents, which increase the risk, especially when we are using, and this will depend upon the amount of antifibrotic agent which you have used, what is its concentration, what is the time which you have used. And it has been seen that leaks are more common, especially if you use mitomycin C as compared to 5-FU. And how much, the way you have applied your MMC during the primary surgery, whether you've used a diffuse application using multiple sponges or you have just applied using a single sponge. So when we have a more localized blebs, you have higher chances of leak. And especially in cases, they can also occur when you've used post-failure, early failures, you've done needling for your blebs and you use antimetabolites while doing your needling. So again, those blebs are again at a high risk of leaks. So first of all, you have to identify patient may be asymptomatic or may have mild symptoms of blurry vision or discomfort, or sometimes if the eyes very, very hypotenuse and a frank leak is there, then the increased tearing may be there. So appearance of the bleb is very important to understand whether a leak is present or not. If it's a low filtration bleb, then you should think there is something wrong. For more mature blebs, look for areas of vascularity, like out here. If it's like for areas of avascularity occurring in this leak, okay? And then IOP may be normal, especially depending on how much is the leak. If it's a minute leak, IOP may be normal in the initial phases. With low IOP, there may be associated corneal edemas or corneal folds, descending membrane folds. And sometimes with a zero IOP, you may have a zero IOP, but the leak may still not be visible even with your fluorescein staining. But look for the other signs of shallow anterior chamber in these cases. And you can identify a leak which is not visible by just direct fluorescein touch by actually doing a Seidl's positive area by applying a gentle pressure out there. And for mature blebs, again, look at the areas of vascularity as I mentioned earlier also, and do repeated and periodic Seidl's tests, not a single period. Maybe first time you're missing it. So, and the other signs of shallow anterior chamber associated with that, they may be peripheral anticyanic case, striae, cataract formation, hypotony, optic swelling is occurring, maculopathy is coming up, choroidal detachments are coming up. So all these things are again indicators of prolonged leaks. So the first thing which you have to do is to stop the flow through the leak. So prompt surgical management, so you have a confirmed leak, you have to on Seidl's. If there is a hypotony which is demonstrated, and if you have flat or a shallow anterior chamber, it means there is a leak which is happening. So in these cases, you can just, you will have to go for a prompt surgical management, but if the leak is found in a routine examination, if the patient was asymptomatic, there are no signs of inflammation, anterior chamber is well formed, in those cases, you are detecting a leak on your Seidl's test by doing a pressure test, then you can go for a conservative management. So early leaks, as I said, can be managed conservatively if they are very small, if there is no signs of infection, if there is visual acuity is normal, IOP is stable, and there is no history of any bleb-related infection. If the leak at the limbus is there, then in such cases, for conservative management, you can use a large bandage contact lens of 16 or 18 millimeters, a collagen shield, Siemens shell, which is not easily available nowadays, or a compression patch. And also advise the patient to wear eye shields at night, especially if the patient has a tendency to sleep prone, where his eyes may touch onto the pillow, and that may cause a problem. And at the same time, you need to alter your post-operative medications, use aquasuppressants, stop steroids, or reduce the frequency of steroids, and use agents like antibiotics which can induce scarring like tobramycin or gentamicin, oral doxycycline, and topical trichloroacetic acid. Besides this, you can use autologous serum alone or combined with sodium hyaluronate. You can do an argon laser coagulation of the leaky areas, or you can apply glue to it. Now, when do we need to move to surgical management? For leaks which are not responding to conservative management, for early leaks, and if the leak is initially itself a large leak or is a diffuse leak causing corneal decompensation, or patient has had an episode of a previous bleb infection, then there is a time when you should switch over not to conservative management alone, but you'll have to take up a surgical management. So Usually these are done for the suture tract leaks or limbal leaks. If they are requiring a surgical management, do a compression suture. So compression suture are placed at the area of the leak. So you can see how it is being managed here. You can just mark the area of your leak, and you can take a wide bite from limbus to from the one side of the bleb to the other side of the bleb. 2 or 3 more compression sutures can compress the bleb, and that will take care of your leak. Well, if your leak is a large one, you may need to use an adjacent conjunctival tissue to cover that bleb which is leaky or sweaty bleb. And there are multiple approaches described for this. One is the minimum invasive approach, where I've described this in these photographs. So you can take an area behind this, dissect the conjunctiva behind your bleb, advance the conjunctiva, and just suture it at the limbus. So you're not dissecting your leaky bleb, you're just suturing the conjunctiva which is behind, a healthy conjunctiva behind it, and bringing it onto the limbus and suturing it out onto the limbus out here. Second is a bleb plication. When your bleb is, in these cases, again, what you're doing is basically you're doing a wide dissection of the conjunctiva beyond the area of the bleb, and then taking multiple O-shaped sutures like this to cover that area of the bleb, causing the flattening of your leaky bleb. So basically, you're going from the area of the non-ischemic conjunctiva, covering your ischemic or the conjunctiva of the leaky bleb, advancing it towards the limbus, and then suturing it out there using large wide-shaped O sutures. For late leaks, you may need to again do a conjunctival advancement, or a rotation flap may be required with or without relaxing incisions, depending on how much is the site of your leak, how much is your bleb area. For this, at this point of time, you need to evaluate whether the underlying scleral flap is also not leaking or not. So that's very important before you do this step. And original bleb is to preserve when there is no necrosis of the underlying scleral flap and the bleb is functional. In these cases, you can just like last 2 slides. However, if the sclera is needed, then you have to do a scleral graft as well, because if the scleral flap necrosis is there, then you need to repair the first your scleral flap and then do a repair of conjunctiva, overlying conjunctiva over it, in order to prevent a Dellen. So for medium-sized blebs, you can just use, as I said, recruit the healthy conjunctiva surrounding it, and then for large bleb, you can just give relaxing incision so that you get more conjunctiva from the posterior area to cover the entire bleb. And for rotation flaps, as I mentioned, if you do not have this conjunctiva, a healthy conjunctiva, you can use a rotation flap, and the principle is going from one conjunctiva and just rotating around. This maintains a vascular supply. Free conjunctival flaps are the disadvantage, obviously, because there's the risk of flap necrosis because of the absence of vascular supply, and recruiting an area in a patient who may require another surgery for glaucoma, you're taking up the conjunctiva from the inferior conjunctiva, so you're losing that conjunctival tissue. This is the last slide. So scleral flap repair, obviously, the partial thickness flap is friable and necrotic, then obviously you'll need to do a scleral flap repair. Or if there's a scleral fistula leading to hypotony, and the donor tissues which you can use is a human pericardial graft, the donor sclera from a donor eye, a reversal scleral flap again, or an autologous free Tenon's graft, or a corneal stromal patch grafts. So these are again videos showing that. So I'll just skip these videos in the shortage of time. Other management options are the amniotic membranes, which obviously works by the antifibrotic principles, injection of autologous serums, or injection of autologous serums, last slide. Or you can use collagen cross-linking. So to summarize, I would just say that monitor your patients closely, especially when you have used antifibrotic agents. Ensure your leaks are fully sealed. Bleb which are formed after surgical repair are more thicker and they have higher chances of failure. So again, you need to monitor your repairs also very, very frequently. May need to start anti-glaucoma medication in these cases early on, because these blebs are at a high risk of failing, and some patients may even require a second anti-glaucoma surgery. Thank you.
Thank you, Dr. Ethan. Now I invite Dr. Amit. Are your slides up now? In the meantime, I will request Dr. Vasudev. Are your slides loaded?
Good evening, everybody. I'm going to talk on pearls for intraoperative gonioscopy for beginners. No financial disclosure. So basically, when you want to start an intraoperative gonioscopy, what are the instruments you need to keep ready? One is a spatula. This is for beginners. The course is basically for beginners. So in the beginning, when you want to learn gonioscopy, you should have the needle with a 2cc needle with a 24 gauge needle. This is how you are going to prepare the goniotomy blade. Just 80 to 90 degree, single bend. You see, there should not be any ragged edges. the bend should be in such a way that the two parallel cutting edges are always there, because you need to cut the trabecular meshwork that time. Adjustment of the microscope is very, very important. You have to tilt the microscope towards you. So when you tilt the microscope towards you, usually you are working like this, but when you tilt the microscope, your distance increases. You have to tilt the head of the patient away from you, 45 degree, and should tilt the microscope towards you by 45 degree. So when you have this, then you have an en-face view of the angle when you place the direct gonioscope. I'm showing you this video in a PIP mode, so that when you tilt the microscope and the patient's head, how does it look? Your eye is not focused because your distance is changed. So you have to focus the eye. Always put a high density cohesive viscoelastic substance into the entry chamber after you have implanted the IOL. So this is basically taking into consideration that you have done your cataract surgery. Now you want to practice your gonioscopy before you do any mixed procedure. So put a sodium hyaluronate on the cornea, place the gonio lens, try to visualize the angle. Now initially when you want to visualize the angle, it should be always in the low magnification, because you are not aware how does the angle will look in a high magnification. So once try to visualize, don't bend. Now you place the goniotomy inside. This is again for beginners, so you're not going to do any goniotomy. You should be able to see that my hand is reaching the trabecular meshwork. I should have free movement of the wrist. How many clock hours I'm going to basically do the goniotomy. So you should rotate the wrist and see how freely your wrist rotates. So this is a learning thing without starting the procedure. So you should observe also that when you place the gonioscope, if you depress the gonioscope too much, how the angle structures get obscured. If you lift the gonioscope, air bubble and all will come. That will hamper your view. So this is just to demonstrate how you are going to start practicing your gonioscopy. So now in low magnification, you feel you are seeing the trabecular meshwork. Now increase the magnification and then see how much is your field of view. Because in low magnification, you feel you're done. You can reach 2 to 3 clock hours very easily. But in high magnification, you see I have to rotate the eyeball with the gonio to get a good 3 clock hour, basically the view. So this is again more increased magnification, and now you know you have to work basically in this magnification when you are going to do any mixed procedure. So the trabecular meshwork should be easily visible. You have to practice your gonioscopy. After every cataract surgery, place the gonioscope and try to practice. This was the lens which was by Vogue. It is a suspended lens. So the en-face view, you don't have to tilt the head and the microscope so much by 45 degree. This is a disposable Catina lens which is available in the market for about 3.5 to 4,000 rupees. You can ETU it and use it. So this is why when you can't invest about, that was costing 98,000. This will cost very reasonable amount. So you can buy this disposable lens. Try practicing your gonioscopy. You see every lens, the field of view is different and the depth of view also is different. So again in low magnification, due precaution is taken. And now you have to be careful. You are going to reuse these gonio lenses. You can see on the surface there are a lot of marks. So these are the cleaning marks. The lens has not been cleaned properly. So all these minute things are going to be very useful for you. You should make sure that the lens is totally clean. Again you practice how much is the TM which is easily approachable. If your wound, your main foci wound, you can see in this it is hydrated. So there are a lot of striae there. This also will obstruct your view. When you are not steady in your hand, when your gonio lens is moving, you see the blood oozing from the side port comes into your view and hampers the view. Quite a few times you end up in lifting or tilting the gonio lens, and if the visco is not a cohesive viscoelastic, you will see these air bubbles coming into a view and they are obstructing the angle view. So all these minor precautions are very, very important. This is another disposable gonio lens which is manufactured by Ocular, which is available for 3,500 rupees. This is the best lens I feel because it has a soft contact lens kind of material. You see this? It has a soft contact lens, so even the side ports are covered by the contact lens. Only the main tunnel is exposed from where you'll pass the needle. So the blood and all coming into the view is obscured. It has a small stem, so you don't have to literally, your left hand is almost free. Just slight touch here and there. You see, I'm just doing a slight touch. You can see the finger movement also in the PIP mode. Just slight touch here and there, and you can visualize the whole angle. The clarity of the image with this lens is much better than the other lens which I demonstrated, the disposable one, what I mean to say. Increase the magnification. Now you can see the TM is, I'm just sweeping my needle across the TM. You see the needle also, it has a tip like a KDB which cuts. It has the two bevel edges which will form that groove. So depending on how much you bend the needle, that much deep will be the groove, or that much wide will be the groove basically. So only the first 1 millimeter you have to bend so that you get an adequate groove and you are cutting only the trabecular meshwork and just exposing the lens canal. So this is the best lens I feel for beginners because your side port and all is covered. So there's no blood, there's no air coming into the way, because when you're going to remove this lens, it is like a suction. So basically we have those suction hangers So how you pull it out? So you have to be careful now. So in this, when we are going in one direction, you to increase the goniotomy, you have to go in the other direction also. And you saw the round red ring which was there. What was that basically? When I was rotating the goniotomy inside, it hit the Descemet's membrane also. So you have to be very careful when you're maneuvering because your working space is less. You saw the way suction was there, and we have to remove with great difficulty. So this is the best lens. After you have done the goniotomy, again you have to readjust the microscope. You have to readjust the patient's head, and then whatever visco is there, you have to wash it. When you do a bang procedure, a GAT procedure, there will be a lot of bleeding inside. That's a good sign. So you have to make sure that you just go on washing it. So basically, this video, which I was demonstrating with the PIP view, is the ergonomics has to be taken into consideration, and there are 3 types of lens based on the pocket value or pocket of yours. You can go ahead for a 98,000 Vogue gonio lens, or you can go for a 47,000 Schwann-Jacobs gonio lens, or you can go with a disposable gonio lens. What are the difficulties we can have? This is a small 1-minute video which is going to show you. See, the wound hydration is so much with the direct phaco. When you have placed the gonioscope, there are air bubbles. Now you have to be patient. You have to remove it again to make sure that the air bubble goes. Don't fiddle with the gonioscope and don't try to rotate the eyeball and try to just andazmar, try to do the goniotomy. That means it is not going in a proper direction. Never do anything without direct visualization. Always visualize what you are touching, what you are cutting. In this, the drape was not draped properly. You see with every breath, there is a fogging going on. So you can't go ahead with your procedure without a proper view. You can see in this, I went through the side port, but the air bubble is always there. Why? Because the palpebral fissure was narrow, the lens was not fitting properly. So the soft contact lens gonio lens won't be suitable if the palpebral fissure is narrow. Always make sure that you visualize what you are doing. Your sister has a habit of putting saline all the time on the cornea. So you put the gonio lens, she is working subconsciously and she'll put a drop on the gonio lens, and you are focusing only at the angle. You are looking at the water droplet which is there, and suddenly when you realize your view is getting obscured. So all these minute trips when you're starting your early learning curve for the gonioscopy, these are all going to be handy, and this is what I wanted to demonstrate through this video. Thank you. So if you allow any queries after the session is over, I'll be outside. We can have a discussion on it.
Thank you, Dr.
We invite the next speaker. Yeah.
Presentation. Now, Dr. Vasudev on left radial management.
Good evening, Jay. Good evening, my friends. I take it a great privilege to take this an opportunity to speak a few words on left radial management. Today I'm going to talk on the most commonly encountered complications which can occur even with an uneventful filtration surgery. The available literature shows that up to 50% of all successful bloods go into failure at some other stage. Even with the use of anti-metabolites like mitomycin C and trichlorouracil, even 20 to 50% of all the successful bloods go into failure 5 years after the surgery. So it's common to find a failing blood. So looking at a failing blood, don't get disheartened. Just be prepared to pick up early signs of blood failure. All that we need to know is that the knowledge to pick up these early signs. So what is an ideal blood? An ideal blood is a low, diffuse, relatively avascular, few microcysts which can pick up on a gland. So the typical failing blood will show a lot of conjunctive hyperemia with dense vascularization and few corpuscle vessels on the blood area, which is followed by raised IOP. Usually the blood is low to flat, and we don't find any microcysts and a dense Quinon's capsule. So what are the predisposing factors? Usually conjunctive hyperemia, secondary to chronic use of anti-glaucoma medications, neovascular glaucomas, acute inflammation, secondary to uveitis, young age, congenital and juvenile glaucomas and traumatic glaucomas are the risk factors. So I think with this knowledge, I think we can be able to fix a failing blood. So all that we need to do is to do a thorough slit lamp examination, note down the antechamber findings, record the intraocular pressure, and do a gonioscopy. So coming to the causes of failure, it starts in the OT itself. Usually the surgical technique, which is more important, which is the scleral flap, which is too tightly sutured, is the most common cause, and the plug sclerostomicide, imperforator, viscoelastic one surgery, or an excessive wound healing process. The most common cause, as I said, is a tight scleral flap, which causes raised IOP during the first week of the surgery. So this we can manage with a digital massage. It's a very useful technique, provided the sclerostomy site is open to be confirmed on gonioscopy. The goal of this digital pressure or ocular massage is to push the aqueous into the blood, which causes weakening of the collagen structure in the blood, making the blood more permeable. So even with the digital massage, the intraocular pressure is not in the target range. Then the next resort is you have to go for a laser suture lysis. So for this, we need a urban or green laser machine. You need to have a Hoskins lens or a 400 Goni lens. The settings for laser suture lysis are 400 to 600 milliwatts with a spot size of 50 to 100 microns for a 0.1 second duration. All that, be careful not to lyse all the sutures at the same sitting. So for those surgeons who don't have an access to argon or green laser, the reusable sutures come handy, where we can successfully titrate the intraocular pressures without sacrificing the long-term benefit of control. And the next cause is a plaque sclerostomy site, which can occur following a digital massage when the anterior chamber gets shallow and your surgical PA is small. For this, you need to be patient, put pilocar drops every 10-15 minutes, and sometimes you need to do a surgical manipulation to pull away the iris from the sclerostomy site, or you have to use an argon laser to chip away the iris from the sclerostomy site. Last but not the least, a blood failure which occurs lately has to be managed by blood needling, either at a slit lamp or you have to take the patient to an OT. Thank you. The take-home message is you need to follow the patient very closely in every post-operative period, look for the early signs of failure, and if the level of failure, you have to be prepared for the unpredictable surprise. Thank you.
Thank you, Dr. Vasudev. Now we'll go ahead with the next talk by Dr. Shalini Mohan. She's going to talk on cataract and trap tips and tricks. After that, we'll have Dr. Shri.
Thank you so much, Dr. Amit. Good evening, respected chair and delegates who are still here. Almost 6 o'clock. Thank you so much for being here. I'm going to talk about cataract and trabeculectomy, refining the surgery. So whenever we get a case of cataract and glaucoma, either we can perform cataract surgery alone if IOP is well under control. We can go for a combined surgery, trabeculectomy and cataract, or cataract followed by trabeculectomy. So depends on which type of glaucoma are we dealing, whether it is mild to moderate or advanced glaucoma or visually significant cataract after trabeculectomy. So what are the special considerations we need to think? There can be poor pupillary dilatation, so we might need sphincterotomies, we might need pupil stretching devices like or mechanical dilatation by iris hook or Malugin ring, whatever you are comfortable with. Then there might be inadequate anterior chamber visualization, there might be shallow anterior chamber, and anesthesia obviously in which you are comfortable with. So whenever we are going for a combined cataract and glaucoma surgery, the advantages are patient convenience, avoiding potential post-operative IOP spikes and long-term IOP control. But there are disadvantages. There can be more intraoperative and post-operative complications, and cataract surgery in patients with glaucoma may prove to be more challenging, and vitreous loss may lead to further failure of glaucoma surgery. So now this is the combined surgery from the same site. So whenever we are doing it from the same site, we have to we do our routine phacoemulsification. So this is performing of capsulotomy as we do it routinely. But whenever we are doing a combined surgery from the same site, superiorly we need to make a conjunctival flap. So I make a Fornix base flap, and that is what I am making. So try to hold the conjunctiva with a non-tooth forceps, a gentle cautery, and then followed by you need to make a 4 flap as we do for trabeculectomy, but this has to be only a scleral tunnel as we do for small incision cataract surgery. Enter the anterior chamber and complete your phacoemulsification. You can see this tunnel which is 4 into 4, and after completing your phacoemulsification, you can convert this tunnel into the partial thickness scleral flap and can proceed for trabeculectomy surgery. So I've just fast forwarded it, and after doing a nice cortical cleanup, implanting the IOL, and you need to inject the pilocarpine in the anterior chamber. So through same tunnel you can inject the IOL, any IOL whichever you have planned, and actually this IOL flipped, and then I need to again rotate it inside the anterior chamber, and after rotation you need to convert this tunnel into the trabeculectomy flap by cutting it from the sideways. So now you can see this is the tunnel, holding it and cutting it with your 1S sideways so that you can make it a flap. So after that, you need to identify the junction of blue and white. If that is the area where you need to actually enter the AC and punch it. So this is the sclerostomy punch, 0.5 or 0.75 depending on your own convenience. You can punch it at least once or twice. You need to see that the ostium is nicely, it was a smaller ostium, so I enlarged it a bit more. And after you are sure about the ostium size, then you need to complete your iridectomy surgery. So you can see the ostium and now the iridectomy so that the iris cannot block, followed by putting up of the sutures. Releasable or non-releasable depends on your own choice. Now this is the combined surgery from 2 different ports. Again you need to do your making your side port and then doing rhexis as you do. I prefer doing temporal phacoemulsification and trabeculectomy superiorly. Generally I shift to supranasal in such patients, so that if repeat trabeculectomy is required, we have furthermore sites for doing a repeat trabeculectomy. So after that, you need to put a corneal stay suture if exposure is not proper, and then again making a conjunctival flap, and then you can complete your trabeculectomy surgery. So if you see the this interesting study of 1 site versus 2 site phacotrabeculectomy, the conclusion was that both techniques yielded similar results concerning with final best corrected visual acuity and IOP reduction. However, when we talk about long-term control, it is said that 2 site has better long-term IOP control. So cataract surgery after trabeculectomy is another challenge where there are several risk factors. I will directly go on to the video. This is already you can see a superior bleb in this particular area. Shifting to temporal phacoemulsification is very useful in such patients. So again, going for important thing about this is there might be synechias which you might to release. There might be compromised endothelial cell count, so you need to do specular. It is always prudent to use a viscoelastic with chondroitin sulfate to protect the endothelial cells, and then you complete your phacoemulsification. You might need see a floppy iris in such patients, and therefore many a times you have to be very, very careful. So sometimes you might need pupil expanders, a iris hook or a Malyogan ring which you might be using to expand the pupil, because many a times the pupil might not be dilating despite putting various intracameral drugs, and if it is not expanding, you can put some of the pupillary dilatation device which you are using. So there might be iris prolapse, so don't overfill the anterior chamber whenever there is iris prolapse. Be very gentle, because these iris are very fragile iris, and anytime they can actually lead to formation of iridotomy. So after that putting, you can actually continue with your routine phacoemulsification. So this is a small video to show the small incision cataract surgery and trabeculectomy surgery. After making your scleral flap, you have to continue with your small incision cataract surgery, and then you this is just a tunnel you make for small incision, going from the side port and making your rhexis as you do routinely, and then entering the anterior chamber. So once you have done, you are done with your nucleus extraction and implantation of IOL, then you have to put pilocarpine again, and then again you have to continue with your superior trabeculectomy. So this is implantation of in-bag IOL in this small incision cataract surgery. You have to punch it as we did for after phacoemulsification from the same side. And after punching, when you're sure about the size of the ostium, then you have to do iodectomy, and don't forget to put sutures. So to conclude, I would say that pre-operative proper planning, good intraoperative strategies, and adequate post-operative management leads to successful surgery. Phaco or SICS is obviously surgeon's choice. In only trabeculectomy if there is no cataract, but combined surgery if two sides is preferable if you have combined and cataract and advanced glaucoma. Thank you so much for your kind attendance.
So thank you, Shani. We have Dr. Srini now. He's going to talk about clear lens extraction for IOL closure glaucoma.
Thank you, Dr. Amit. Good evening. Before I go into the discussion of on the role of clear lens extraction for angle glaucoma, I'd like to just touch upon some of the studies on role of PI in angle closure iridosis by angle closure iridosis. The Vellore survey has shown that in 36% of cases of primary angle closure who refuse PI, they progress to PACG, while only 11% who underwent PI progress, but still 11% actually progress despite PI. Now, coming to the more recent returns of ZAP and analysis, ZAP basically studied on PACS. PA was done in one eye and the other eye stayed as control. It was seen that even after PI, more than 25% didn't really open. The lab results show that PA actually reduced the risk of PAC by a factor of 2, but the PAC occurred in 4.19 per 1,000 eye years in the treated eyes. Analysis study was done after ZAP was completed. Some of the same investigators were there again on PACS, PA in one eye and the other eye stayed as control. Here also, PI, post-PI, 5% actually progress. So PA does protect, but does not protect all. So there is more to it than just angle pathology, which brings us to the role of lens in primary angle closure diseases. So these two studies from Singapore and Korea, both of them showed in PAC, PACS, and PACG, the lens fault is much higher than in the control. So we have proof that lens actually contributes to shallow anterior chamber. Also, there's a role played by lens thickness. The lens thickness is more than 4.55 millimeter. It actually occupies 30% of the eye volume, and it has been treated as a nanophthalmic eye despite the normal axial length. So the aging lens is increase in thickness, increase in lens fault because of increase in anterior curvature, weak zonules, shallow anterior chamber, relative pupillary block, block of interest and ratio of progression. So that's what happens there. So this brings us to the landmark study, the EAGLE study, which concluded that lens extraction was better than lens of PA, PAC, and PACG. So the multi-center trial, they included newly diagnosed PAC with 30 millimeter or more of IOP and PACG 21 millimeter or more with discontinued changes. None of them had linear cataract, no previous history of ACG, divided into PA group and the clear extraction group. And after 3 years, it was seen that in the clearance extraction group, there was a definite statistically significant lower IOP there by 1.18 mercury. And the quality of life also was significantly better in the clearance extraction group. But it has to be taken with a pinch of salt, because if you see the result, you can see that it's basically those who are actually using glasses +1, +2, +3 and all. So once that is knocked off and they can see without glasses, then the quality of life, they feel that it's better. So that's about quality of life. The drawback of the study is that 60% of about 60% of didn't undergo post-operative. It doesn't give much information about what happens to angle after clearance extraction. Very minimal complications in both groups. So the EAGLE got us thinking about lens as a culprit, but I would prefer to say that it's more of a solution to the problem. So lens extraction works by relieving the pupillary bulk, deepening the anterior chamber, separating the PAs, removing the plato iris component, and increases aqueous outflow. So should we actually remove the lens? So let's see, if there is an acute angle closure, as you all would do, I would definitely do a YAP PA only. Because in this hot eye IOP trap. So if there is a cataract, I would go ahead with cataract surgery along with that, or you can actually defer it. So post PA, if there is no residual closure, IOP is controlled, no clear lens extraction. But I would go ahead with cataract surgery in these cases. At a much earlier stage than what I would do for normal cases. Again, no residual closure, IOP is not controlled, no clearance extraction. Here our aim is basically to control the intraocular pressure. So definitely a trap. If the cataract is there, I'll also take it out along with it. If there is no residual closure, IOP is not under control, and the lens is clear. So and it is showing progressive closure, like new PA is forming. So I would go ahead with the clearance extraction along with trap there. So if there is cataract, no question. Like I would take the cataract along with cataract. If there is residual closure, IOP is under control. If there is progressive closure, I would consider clearance extraction in this case. If there is security cataract, I would do the cataract surgery. Now coming to PAC, so almost similar. So if there is no residual closure, IOP is under control, no clearance extraction. If there is cataract, okay, definitely you have to deal with that. Again, even if the IOP is not under control, here, see, yeah, there is no optic nerve that damage. So you can consider cataract surgery, and the cataract surgery itself will bring down the IOP by 4 mm, and then decide on whether to go for a surgical intervention later. If there is no residual closure, IOP is not controlled. If there is progressive closure, I might go for clearance extraction. This significant cataract, definitely I would go in cataract surgery. If there is residual closure, IOP is under control. Still, if I would go ahead with the clearance extraction, if there is cataract, definitely I would do it. So what are the arguments against cataract surgery? So doing a cataract surgery in a crowded anterior chamber is difficult. But you give IV mannitol half an hour, 1 hour before the surgery, 100 ml. It not only reduce the intraocular pressure, it will actually deepen the anterior chamber, and with all those new OVDs available, you can safely do the cataract surgery. Making them presbyopic, you have those multifocal IOs and the gray zone with all the field effect and all that, there is an option there. So to conclude, whether to go for a clearance extraction or not is based on the status of the angle, the intraocular pressure, the status of the lens and all. So that's it. Thank you.
Thank you, Srini. So now we go to the last talk of the session by Dr. Lakshmi. She will talk on traumatic effect after hypertension.
Good evening all. I would like to thank APUS for giving me this platform to talk about traumatic ocular hypertension and glaucoma. I am not getting the slides here. As we all know, ocular trauma is a frequent cause of blindness, in particular with the development of glaucoma across the world. So ocular trauma refers to a heterogeneous group of ocular disorder. Secondary glaucoma refers to a heterogeneous group of ocular disorder with a high risk of IOP rise, that is ocular hypertension, ultimately ending with glaucoma, with underlying variable different multiple mechanisms for the cause. So it's more common in young active males, in particular in the workplace or any sports injury related. In particular, country like India, we have cracker injuries. So the risk of traumatic glaucoma post open globe, it is around 2.67, and post closed globe, it's more than open globe injury. It can occur either soon after injury or even years later. So these are all the types of ocular trauma which can lead to IOP rise. Commonly we encounter post mechanical injury, chemical injury. Other injuries like thermal, electric shock and radiation injuries also can lead to secondary glaucoma. Mechanical injury, when we come to this, we either closed globe or open globe. Of course, surgical trauma also can lead to IOP rise, in particular post-cataract surgery, penetrating keratoplasty, Vias procedures, buccal procedure. So
what are the causes? We can enlist the causes during early phase as well as the late onset. Early, as we all know, the inflammation is a major cause. Any tears in the trabecular meshwork, hyphema, can lead to early phase IOP rise. Late onset, development of peripheral anti-synaptic, hyperpigmentation in the angles, angle decision, and lens-related factors. Either change in the position of the lens or lens cataract, traumatic cataract with anterior subluxation. In case of open globe, retained foreign body, and Schwartz syndrome, it's RD-induced pigment release causing secondary glaucoma, open angle glaucoma. And late phase, again, one of the most important factors which can lead to glaucoma, and mostly it is missed out, is epithelial or fibrous ingrowth. So chemical injury most commonly encountered in alkali injury. So as we all classify any glaucoma, either primary or secondary, it's open and angle closure, open angle and angle closure. When coming to the closed angle, either it is anterior pull or posterior push due to lens induced, that is iris lens diaphragm push forward. Pull actually due to the development of anterior synaptic. Open angle, either it is pre-trabecular, trabecular or post-trabecular. It occurs basically due to aqueous outflow obstruction by the hyphema or ghost cell. Post-trabecular, it can be due to rise in episcleral venous pressure, post-carotid cavernous fistula. So the mechanism of closed globe injury, we all know there is any concussive injury, there is anteroposterior compression with equatorial expansion with pushing of the intraocular contents posteriorly, again rebound factor. So which can lead to aqueous forcibly displaced laterally and backwards with limbal stretching together. It can result in 7 ocular rings rupture that was coined by Campbell. It could be either pupillary sphincter tear, irododialysis, angle recession, cyclodialysis, trabecular tear, zonular dialysis, and the last is retinal dialysis. So what are the predictor which when we see any traumatic glaucoma, we should keep in mind the following factors. Nowadays, we are addressing them as biomarkers. Predictors for chronic traumatic glaucoma or ocular hypertension. First and foremost, hyphema, which occurs during early phase. Angle decision more than 180 degree. And the high baseline intraocular pressure. And lens related, if there is any traumatic cataract or lens displacement. And increased angle pigmentation or any iris injuries like sphincter tear. So workup, we should have a detailed history elicitation, including the mode of injury, the direction of the force, time since injury, extent of the vision loss, any treatment was taken earlier, prior ocular complaints present before injury, any family history of glaucoma, and followed by careful comprehensive evaluation, intraocular pressure examination, gonioscopy. Gonioscopy should be avoided when there is hyphema, risk of rebleed. Fundus examination. In the posterior segment is hazy, we should go for B scan, and UBM can be done in particular cases. So management based on on my left, these are key points present in the management. Flowchart has been given. If there is a secondary glaucoma due to ocular trauma, you have to make out the cause for it. If you find the cause, you have to address it medically. And if IOP is controlled, then you look for any optic disc damage. If optic disc damage is not there, consider tapering medical therapy, and look for presence of angle decision. In case if there is any angle decision and when there is no IOP rise, when the patient presents to you, the patient requires lifelong follow, because the angle recession induced glaucoma can occur any time between 3 years to 10 years. So on my right, that algorithm says traumatic glaucoma after closed globe injury. Early days and intermediate IOP has to be checked, and if it is the cutoff is less than 28, you have to go for topical and systemic glaucoma medication based on the patient's comorbidities and any other contraindications. And if it is more than 28 millimeters of mercury, you have to go for maximal medical therapy and maximally tolerable medical therapy, which includes parenteral and oral hyperosmotic agents and carbonic anhydrase inhibitors. In case of even with this, the IOP is going to remain high, that's more than 26, we have to go for alternate procedures, surgical interventions like trabeculectomy. If you can't touch the eye, if the IOP still remains, you have to go for a preliminary procedure called diode laser photocoagulation. And if the pressure is under control, we can gradually taper the drugs, but we have to keep in mind the IOP and the angle status and the posterior segment for the optic disc changes. If it occurs late years, then glaucoma medications and surgical intervention based on optic neuropathy. Because when we say glaucoma, then there should be optic disc changes, and if the patient can do fields, you have to document the fields, and it has to be repeated. So here I would like to present a challenging case. In this regard, I presented this briefly about the traumatic glaucoma. So we saw a 45 years old active male. When he was away from the sports activity, somebody was playing, so he sustained a ball injury. His IOP became very refractory. We maximally tolerable medical therapy, and we couldn't post him for filtering surgery. So as a prerequisite to do pre-filtering surgery, we posted him for continuous wave transcranial cyclophotocoagulation, that is in staged, that is sequential and titrated. So instead of doing for inferior 180 degree, we did for 1/3, that is 4 clock hours we did. Then after 1 week, we rechecked again, the IOP was not satisfactory or not acceptable to touch for the filtering surgery. So we went ahead with the next stage, that is again 1/3, 3 new quadrants and one clock hour overlapping the previous DLCP site. To our surprise, but we expected with our previous clinical experience, with this two-staged DLCP procedure, his IOP came down to less than 30, and we could post him for trabeculectomy with mitomycin augmentation and releasable sutures. Touchwood, till his last visit, his IOP came down to 14, that is the complete success. It's not a qualified success without any anti-glaucoma medication. So take home would be, any trauma-induced IOP, it has multiple mechanisms, so we need to address so many factors when we do gonioscopy: increased pigmentation, angle recession, and any sphincter tear. That also indirectly gives a clue that the patient may develop glaucoma later on. So it's very crucial to identify the underlying cause. Visual outcome can be good if we control the IOP and timely management. This continuous wave here, I would like to highlight the continuous wave transcranial photocoagulation can be extended to patients even with good vision. It can be an excellent tool for a refractory glaucoma. It has favorable relatively safety profile. Thank you so much. Thanks.
Can we have a group